Okay, welcome back. We're going to be talking today about treatment planning. Often, for our students who take this class, this is one of the more challenging aspects of the coursework, just because it's probably not something that you did in your undergraduate psychopathology or abnormal psychology class. So just know that this is going to be new, and there's always a learning curve with anything that's new and difficult. But it is, without a doubt, one of the most important things that you're going to leave graduate school knowing how to do, or at least starting to know how to do. You're obviously going to get lots of practice as you go along. Here, we're going to be talking about different elements that are built into the treatment template that we have for the Ariadne's thread cases. And I recognize that these might look a little different than what you do depending on where you are and what your setting is, but hopefully what you practice here will be applicable to a variety of different contexts, whether you're in the school system or you're in a community agency or you're working in a hospital. Here we go. So again, just returning to some definitions here at the beginning. Obviously, last time we worked on the case conceptualization, which is the map of the case or how we understand it, how we piece information together. And this is basically our global perspective on what's happening with the client. The treatment plan is a little different. So, with the treatment plan, you articulate the issues that you're going to address and in what order. So, essentially, it gives some structured hierarchy to what we're going to do, where we're addressing the most pressing things first, the kind of subsequent issues, or the pressing issues first, the stabilization, then the subsequent issues, the root issues, and then how you're going to terminate in the last 2 to 3 sessions. And in that situation, you're going to really work on how you can highlight and reinforce the gains. So again, it's stabilize core issues and then work towards termination. Some tips. Let's see here. So treatment plans can also include actions to be taken, such as referrals to other professionals, psychiatrists, career counselors, speech language pathologists, couples counselors, nutritionists, things like that. But the best treatment plans directly address the primary diagnosis and they'll outline the expected outcomes of treatment. So by the time you get to your treatment plan, you should really already have articulated your primary diagnosis. Obviously, some of these are provisional and we may come back and adjust them accordingly. But the important part is this that you have to have a primary diagnosis. If you don't have one, it's going to be really hard to write a coherent treatment plan. The sections. In the first section, you're going to use this as a repository for writing up problem behaviors and symptoms. This is basically where you will derive your goals for the treatment plan. And then you're also going to write the DSM diagnosis underneath that. I want you to think about this as just an opportunity to think through what it is that's going on with our clients that we should be addressing. So if you've diagnosed your client with major depressive disorder, you'll want to mention sleep disturbance. You'll want to mention low mood. You'll want to mention feelings of hopelessness. You'll want to mention appetite changes. So these are all things that are symptoms that are showing up. And you're going to want to make sure you use that first section in the template to be a repository for that. So the next section, section 3, really is the goals for your treatment plan. And they should be written clearly and concisely. You want to have a goal A, goal B, and goal C. In general, you want to be collaboratively working with your client to determine what the treatment goals are. You want to do your best to privilege the client's own self-direction or as best as you can from the case. I think it's really important to be mindful of the kinds of goals the client might have for themselves, particularly for folks who maybe work in the schools. A lot of times you'll end up with a client who is mom or dad or teacher or principal wants something to happen, and it maybe doesn't align with what the client wants. So it's always a little bit of a balance when you're working with situations like. So you want to write your goals out first. You're going to think about the initial goal. The initial goal should really target the problem that is bothering the client the most. Think about what parts of the primary diagnosis you can really relieve in this first goal. For instance, going back to our client who's struggling with depression, a great way to get someone to sleep better is getting them to be a little bit more active during the day. That goal there could be to increase someone's daily activity, or actually, sorry, it would be to improve someone's sleep and sleep hygiene. So that could be your first goal here. And then you would think about how you would go about doing that. So, a subsequent goal, obviously, this is the core underlying issue. What needs to be addressed for the client to not return? Essentially, we have to do this because if we don't address this core issue, it's likely that after stabilization, clients will return. Sometimes it can be hard to get client buy in on this part of the treatment plan because they're like, oh, my depression symptoms are better. Why should I continue to going to counseling? And then you would really want to articulate that sometimes there's something else that's going on under the surface, and we really want to make sure we address that. And then finally, the closing goal, how you would do the last 2 to 3 sessions, how we conclude our course of treatment, how do we consolidate the achievements so far, and how do we enforce that? A big part of this one is that we don't want to introduce any new goals. We want to just focus on what we've done and prepare for the future, but no new goals. So, just giving you guys a case example. So, thinking through a client who maybe has some anxiety and they have generalized anxiety, that's their diagnosis. So, the initial goal would be anxiety reduction. So, that's the stabilization, addressing the symptoms that are tied to the primary diagnosis. And then the subsequent goal would be to address any deeper feelings of shame or guilt that person feels, that they're concerned about the appraisal of other people because they were raised under conditions of worth and are worried that no one would really like them if they knew them. Again, great subsequent goal, great work to be doing in counseling. And then the closing goal, of course, should focus on coping with anxiety, shame, and guilt. And the closing goal should not be something like reduce depression. When you introduce something new, it's going to extend treatment. And for the purposes of our class here, just to give you some practice on treatment planning, we're just going to focus on these 3 goals. The next step after coming up with the goals is coming up with interventions. And you really want to make sure that the interventions that you pick are aligned with your goals. Are they somehow going to target and support the goals that you've created collaboratively with your client? And also importantly, they need to be consistent with your theoretical orientation and any initial interventions you described in the case conceptualization. For instance, if you picked REBT in the case, you're going to want to make sure that you're picking interventions from that theory. For example, you'd pick the ABC analysis or you'd pick the self help form. And then the next section is the expected results. These would be the outcomes, and these should be really clearly identified for each goal. What improvements would you want to happen based on your intervention? Really keep the end in mind when you're writing that, and just make sure that you are progressing through treatment with markers for success. Because if we don't have measurable results, we don't know when the client is achieving them. And then it's really hard to justify continued sessions to an insurance company. And if you're struggling with this, you can think through what would it look like if the clients made some improvements. We'll give you some examples. Ultimately, related to this is the measurement section. It's a hard section, but it's also one of the most important since it's used to ensure that we are having outcomes and we're meeting our clients' goals. I want you to think through how can you demonstrate any progress using numbers? That gives you something concrete. And it's really hard to articulate your treatment plan or progress to insurance companies or Medicare without numbers. And so you want to think, when you're thinking about measurements, you'll want to also think about measures that match the diagnosis. So if you want to use assessments, pick one that matches the diagnosis. For example, Beck Depression Inventory, which is in Brightspace, is a better measure for depression than the Beck Anxiety Inventory, and vice versa if you're dealing with depression. So that's a great way to do it. And you can look at where's your client when you start and what would a good reduction be like before you move on to your next goal. How about something for relational issues? Maybe the client is fighting with their partner somehow. And how would you quantify that? You could say, how are things going? Is it going better? And the client would say, yes, sure, it's going better. But that's really not a great way of doing it. So you would want to say something like clients reduced arguments with spouse from 5 down to 1 in a week. You want to just make sure you have quantifiable markers for success. And yes, sometimes you have to be a little bit creative with it, as the case with that one. And related to that, like I just said, that it's not a great idea to ask the client how things are going with their spouse. We really want to avoid using verbal self-report. And we don't want to use it because it's basically unreliable. And I think it's much more useful to try to use some standard measures, even though obviously standard measures involve self-report, but they tend to be more rigorous and robust. And some examples of that would be obviously the DSM-5 TR level 2 assessments. Again, those are in the Brightspace classroom. So just make sure that as you're working on your treatment plans, that you go through and find some measurement tools that work well with what it is that you're wanting to do. Another option is obviously scaling. And these are some other ones: outcomes rating scale, the session rating scale. These are very brief measures that are aligned pretty well with solution focused brief therapy. But scaling can also be used to help quantify self report. Maybe you could have the client scale their readiness to change. You could scale their pain. You could do 1 to 10, 1 to 5. I will admit that it is prone to bias, but it is an option if you honestly can't come up with anything else that relates to what it is your client is struggling with, and there's not a great measurement report. But again, better than scaling would be a frequency count. Clients are asked to track something that happens, which tends to be more reliable than a self report. We can have them track the frequency, the duration, the intensity. So, some examples of frequency would be number of alcoholic drinks in a day, number of suicidal thoughts in a week, number of panic attacks in a month. When we could all say we're starting at 12 panic attacks in a month, we'd want to get that number down to 4 or something. And that would be a good goal and an easy way to measure progress. Examples of duration: the time length of drinking episodes all day versus a couple of hours, time length of suicidal thoughts, time length of panic attacks. This is a really good one for working with people with panic attacks because it it encourages clients to realize that they really only last for a few minutes when they may ordinarily assume that their panic attack is lasting for an hour. And then some examples of intensity. So, severity of drinking episodes. Are you getting tipsy? Are you drunk? Is it a whole weekend bender? Severity of suicidal thoughts: mild, transient, moderate, persisting, severe. And then the severity of the panic attacks. So, mild, moderate, and then severe. And that can be a great way to measure some progress too. When we're thinking about our case example of Duncan, we should ask ourselves, what symptoms must we address to first stabilize Duncan? That's our initial goal. And of course, Duncan was diagnosed with PTSD, and we're aiming to address some of his dissociative symptoms. We could also look at maybe avoidance or the numbing if he's having difficulty to engage with others. So that would be our goal 1. And then we would think about what is the root cause that must be addressed for Duncan to make a long-term recovery. Again, this is the subsequent goal. In Duncan's case, maybe some grief and loss, some significant amounts of guilt and regret. And we want to be addressing this grief and loss and the cognitive elements, which obviously are perpetuating his low mood and his feelings of sadness. And then lastly, how would you terminate therapy with Duncan in those last 2 to 3 sessions? What gains are most important to highlight? You want to make sure that he has some tools to handle his dissociative symptoms. You want the grief and loss, feelings of guilt and regret to be worked through. And you want to have made some headway into the acceptance of the event. We have to learn from things that happen to us, and we have to move on from them. This is really going to show you some examples of how theoretical orientation really matters a lot less than you think. It does matter, but essentially, you can use any theoretical orientation to treat whatever presenting concern in primary diagnosis you want. So we're going to talk a little bit about, we're going to compare a CBT approach to a person-centered therapy approach. So anyway, hopefully that'll help you see that you could really play around and pick some different theories and still have a really good treatment plan. If we are working with dissociative. So it was CBT. So let's think about that. So we'll do CBT first. So with Duncan's associative episodes, we would want to focus on those. It would be really important to make sure that he's got some tools, grounding techniques, mindfulness, the ability to stay in the moment rather than become lost in a flashback. So that's how we would approach that from CBT. The subsequent goal would be grief, loss, and guilt and regret. So we would, to target the guilt and regret, we'd want to help do a cognitive appraisal of the situation. We look at the core beliefs that maybe Duncan has, that we feel guilt based on how we appraise our own behavior and how Duncan thinks about his own responsibility. And using T, we can improve the self-talk, we can improve his beliefs about himself to try to make things more positive and honor the memory of his girlfriend. So that would be how we would address the guilt and regret, thinking through that cognitive triangle and how we can change beliefs. And then that changes ultimately our feelings and our behaviors. And then lastly, for our closing goal, again, just really underscoring the dissociative work we did with dissociative symptoms and also the guilt and regret. We want Duncan to continue to be able to function, hold down his job, and not feel held down by significant feelings of regret. And because he's done that, we really want to practice these skills while he's processing his grief and processing his guilt and his regret. So it's just like really supporting him and recognizing that he has done a lot of work and that he has taught himself some skills to help him cope and has made some meaning out of it. And then you're going to want to develop a long-term plan post-therapy for how we will prevent relapse for the dissociative skills or the guilt and regret. So we're going to, again, practice mindfulness skills, grounding skills, and encouraging him to continue to keep a diary or a log. And then making sure that he's aware that he can have check-ins with you. So that's what a CBT treatment plan would look like for our guy Duncan here. And then for our next client, which is a person-centered one, our initial goal for Duncan maybe be his withdrawal from interpersonal relationship, his lack of trust. So the first goal would be to try to establish a therapeutic relationship so that he can start to open up to you and then hopefully open up to others. So as he shares his thoughts and feelings with you, he starts to realize he can take some risks and share his thoughts and feelings with others. And this is a great goal from a person-centered perspective that still targets his primary diagnosis. Again, the subsequent one, but here again, you wouldn't want to be using grounding skills if you're doing person-centered because that's not an alignment. So for the second one, you'd want to address the grief and loss. And you'd really do that. The interventions would be reflecting feeling and meaning and helping the client to really stay in their experience of grief and not try to avoid it, encouraging them to process their feelings related to their girlfriend's death. And if he's not able to really process this loss, then he may struggle to continue to open up to others out of fear of loss down the road. So there's some high stakes here. And then third, the closing goal, just ensuring that he's become more open and that Duncan's processes grief and loss. Encouraging the client to talk about his relationship with therapists can be a good intervention here, and to be curious about how he's been able to open up. What's it been like for him having someone to listen to him? And just using these non-directive listening techniques, we can encourage him to really talk about what it's like to be there with you processing his grief. And really articulating how his work with you as a therapist has helped him regain a sense of control of his relationships, and he still believes that he matters to people. Again, a very different closing goal than we would do with a CBT, but one that would be arguably just as effective. Oh, great. That is our stop sharing here. That is the end of our lecture. Thank you guys so much for your participation and focus.